Okay, so our little girl was Lily, who's a 7-year-old first grader at Liberty Elementary School. She has been diagnosed with spastic quad CP and PVL. She has a twin brother, Cash, and also had an identical twin who was lost at 17 weeks gestational age, secondary due to complications of twin to twin transfusion. At 3 months old, it was observed that Lily had increased tone and developmental delay. She currently receives Botox injections in her hamstrings and adductors to help combat spasticity. Lily also attends PT, OT, ST in school, as well as outpatient PT, OT, and horse therapy once a week. Lily uses a power wheelchair for the majority of the day for mobility, a Riften walker for ambulation, and a Riften activity chair for playing and eating.
So during our examination, we observed her posture in standing, sitting, and supine. 4-point stance. Her muscle tone was assessed in both all extremities, along with our active range of motion and passive range of motion. There was decreased range of motion noted in hip flexion while her knee was extended in the 90-90 test, and spasticity in her lower extremities at a level 2. There was decreased hip abduction, also noted. Ankle plantar flexion and dorsiflexion was not measured in this session because we didn't take her AFOs off. We're planning on doing that this session. Floor mobility was assessed through having Lily military crawl to an object about 3 feet away. This was a difficult task for her, and she was mostly using her upper extremities. Transfers from supine to sit to stand, and floor to stand were all done with a mod assist of 1. This is becoming harder for Lily and her caregivers as she grows older and heavier. Sitting and standing balance was observed. She requires trunk and upper extremity straps while standing in her gait trainer and has minimal control where her trunk leans. In sitting, she requires external trunk support, such as the one of us holding onto her trunk.
Okay, so the top 4 problem areas that we found were truncal hypotonia, causing her difficulty with sitting independently, transferring, ambulating, and keeping a healthy posture of her back during all these activities. Hypertonia in the lower extremities prevents her from bending her knees to get into a 4-point position and crossing her legs on her own when she's sitting up. And this causes her difficulty with moving her lower extremities while walking with a gait trainer. Also, weak upper extremities and trunk causes difficulty with maintaining a 4-point position, and weakness and spasticity in her biceps causes slower reaction time to catching a ball and difficulty with the motion of throwing. And this is a participation restriction as she enjoys playing baseball.
All right, so her main problem area is the hypotonia that affects her trunk and her core. The importance of core strength in helping us maintain posture is something we've learned about a lot in school. It's also active for most of our movements we make. Her hypotonia-induced trunk weakness is partially to blame for all the motion that she is currently struggling with. Some of the motion skills we observed deficits in that can be attributed to this core weakness is independent sitting, ambulating, and transfers like sit to stand, prone to 4-point, hold to stand, transfers like that. This hypotonia of her trunk is going to continue to be a problem as she ages, and it might actually get worse and cause more severe mobility issues as she grows and gains height and weight. So for all these reasons, we believe our main focus should be on strengthening her core, because this is the area we can help most positively affect her overall mobility as she continues to grow. So a couple of things that we wanted to ask our instructor about we've been having some difficulties with, we're just not quite sure on, is how to improve her 4-point positioning. This is something we struggled with a lot during the first session. We want to know how to get the most out of her treatment to positively impact the patient. How can we best address her core weakness? And then is there anything we can do to work around the lower extremity spasticity during our treatment hour? Her Botox in her hamstrings is just about worn off. Last week, with enough effort, we were able to move her legs in a position we wanted, but sometimes they would hurt her knee. So those are our things we were wondering about.
Okay, and then some things we wanted to work on during our next session is the sitting on exercise while hitting baseballs, supported standing while shooting baskets, 4-point position with a large bolster under her pelvis, prone on exercise ball with reaching, so we can put like a puzzle in front of her, and then that Riften walker for standing and walking purposes.